Alright, so we're going to start the third part, which is infections. So, we need to look at primary prevention, which is done through vaccines, modifying risk factors, education, and secondary prevention, which is done through screening. These are all clinical managements of immunity. So your active immunization drugs are going to be your pneumococcal vaccine, your typhoid vaccine, your hepatitis A and B and B vaccines, your flu vaccine, and your MMR live, your rubella live, etc. Now your passive immunization drugs are going to be your CMV, your hepatitis B immune globulin, your immune globulin. This could be done IV or IM, given IV or IM. Your antitoxin and antivenin drugs, your diphtheria and antitoxin, and your tetanus antitoxin. Now, some key points about vaccines is you want to make sure that you check the expiration dates. You want to check with these patients to make sure they don't have any egg allergies. You want to be prepared to administer CPR because of anaphylaxis. You also always want to have epinephrine available for immediate treatment of any kind of anaphylactic reaction. You're going to observe these patients for 20 to 30 minutes after an injection, and then you want to make sure you update their immunization record. Now, infection is a process involving the invasion of the body by microorganisms, the multiplication of invading organisms, and the subsequent tissue damage. Now, these agents are going to be called infectious agents. And here's your chain of infection. You're going to have your infectious agent, your susceptible host, port of entry, mode of transmission, portal of exit, your reservoir. So, for your compromised host precautions, you're going to do infection control. So the best way to prevent this is you want to do medical asepsis, surgical asepsis, aseptic non-touch technique, standard precautions, and transmission-based precautions or isolation precautions. So let's ask some questions. Which technique can be used for these different things? So peripheral IV insertion, what would it be? Urinary catheter insertion. So peripheral IV insertion would be what? Medical asepsis. Urinary cath insertion would be what? Medical asepsis. Insertion of NG tube. Aseptic non-touch technique, right? Central venous catheter dressing change. Medical asepsis. HIV patient with a surgical wound dressing change. Okay, go through these and answer them and figure out. So when it's unclear, err on the side of safety. So factors to consider when you're looking at these is the setting, is an acute care versus a patient's home. Their immune status of the patient. So is there underlying disease, age, medications, procedure? The type of wound. Is it acute versus chronic? Is it clean versus infected? The location and depth of the wound. And the invasiveness of the procedure, for example, whether debridement or extensive packing of the wound is to be performed. That helps you to make some determinations. So assessment of an infection. What you want to do is you want to look at your chief complaint. So is there frequent or persistent infections? Does it bleed for a long time? Do they bleed for a long time when they're cut? Bruised? Do they bruise easily? Do they have chronic fatigue? You also want to know about their history of cancer or prior treatment for cancer, HIV infection, history of a splenectomy or indwelling venous access device. That would indicate the patient needed long-term venous access. You need to look at their medications. So is the patient using, or is it a recent change in any kind of medication? Is the patient using, what type of medications are they using? Have they made any kind of recent changes that could suggest any kind of underlying immunologic problem? You also need to ask about any kind of recent immunizations. You need to know about their family history. Is there any kind of family history of any kind of immunologic disorder, such as cancer? You're going to do a review of systems. So you want to look for any kind of reddened. You want to ask them about any kind of reddened, swollen, painful, warm areas. You're going to ask about fever or chills, night sweats, breaks in the skin, ulcers, lesions, lymph nodes, enlarged lymph nodes. You're going to assess for any kind of weakness, lethargy, malaise, apprehension, headaches. You're going to ask about sinus pain, any problems with breathing or having a persistent cough. Do they have any pain or burning with urination? What is their primary symptom that they have? You're also going to conduct a physical exam of that patient. So, diagnostic of an infection, basically the agent is deduced by observing the client's signs and symptoms similar to a person exposed. Most of the time you're going to make an educated guess on what they're going on with them. You're also going to obtain specimens, so blood, urine, stool, sputum, throat, etc. They're going to be done under a microscopic exam. Usually going to have a gram stain and culture sensitivity to determine the type of organism that you're dealing with or infection. So your signs and symptoms, like we talked about, they could be localized infections, and that's going to cause redness, pain, warmth, swelling. Could be pus at the site. Generalized infections usually aren't going to show any kind of signs apparent to signs like you would in localized infections. The pain could be mild to severe depending on its location. Warmth is generally expressed as a fever. It could show signs of malaise, anorexia, prostration, fever, diagnostics. So remember, once a person becomes infected with a pathogen, their symptoms may or may not be apparent at that time. So your nurse's role in prevention. you need to have a game plan ahead of time, okay? You need to practice and promote hygiene. So you need to wash your hands when you enter a room, when you leave the room, after any kind of procedure or before any kind of procedure. You want to make sure you're washing your hands. You want to have consistent use of aseptic technique. Okay? You're going to use standard precautions unless otherwise indicated. You're going to do patient assessment and additional precautions depending on the patient. So if they're immunosuppressed, you're going to have neutropenic precautions. You want to do patient education. So you want to educate them on how not to cause infections or how not to pick up infections. If they're immunosuppressed, you're going to talk to them about that. You're going to use safety devices. So, you're going to remove any kind of unnecessary equipment. You're going to use care bundles, or you're going to use bundles that are already done up to use, so it cuts down on the type of infections that can be used. It's better to have a sterile, such as a Foley. It's better to have a sterile kit with everything in it that's all sterile than to have 4 or 5 individual kits. You want to make sure that you're fit for duty before you do deal with the patient. Do you have anything that's going to cause an infection in that patient? And then you want to participate in core measures. So, some special considerations. You have to look at your setting. So, if it's an office or a clinic, anybody with a communicable infectious disease or is immunocompromised should be placed away from other patients. When administering an antibiotic in a clinical setting, you want to inquire about allergies. So you have your patient tell you that they're allergic to penicillin and the doctor prescribes a shot of Kefsol. What are you going to do about it? Okay? You're going to ask them to stay and monitor for an adverse reaction. I would do this when administering any kind of antibiotic to a client. Cephalosporin drugs that you are closely related to penicillin. It's not 100%, but a penicillin allergy can be, they could be allergic to that as well. Kefsol is a first generation cephalosporin. You want to look at their home setting, hospital setting, take into consideration infection control, long-term care, surgical unit. You have to look at other things that can affect that. So their age, do they have a surgical wound or trauma? How is their immune function? What kind of chronic illnesses do they have? And what kind of activities do they participate in? All these things can affect. You want to make sure that you urge the patient to consume adequate fluids. Fluid intake is important in the transportation of nutrients to the cells to fight infection. You're going to encourage the patient to consume high protein, high vitamin diet. Because we all know that protein helps in what? In fighting infection, building the immune system up. You're going to put them in isolation if it's required. You're going to run laboratory tests. So you're going to check on the white blood cell count, the ESR, their iron level. You're going to culture the urine, blood, any kind of wound or throat cultures. You're going to administer the proper antibiotic drug. If they need it, you're going to use hyperbaric oxygen therapy. You need to always make sure that you caution your patients not to stop taking their medication once they start feeling better. They need to go through the whole process. If they're prescribed a 2-week period of antibiotics and they start feeling better after a week and a half, they need to finish that course of antibiotics, not stop it. So the different types of infections, you got community-acquired infection and healthcare-associated nosocomial infections. Okay? Now, many viral infections are pervasive in society and occur at certain times of the year. So you know that the flu occurs at certain times of the year. We know that pneumonia can come at any time of the year, but it's more prevalent usually in the winter months. We know when most childhood illnesses are prevalent. We know about foodborne illnesses, what causes those. We know that poverty, low immunization rates, overcrowding, unsanitary living conditions, all these things play a role in infectious diseases and how well they're controlled and what type of diseases can occur from those. Now, community-acquired infections are acquired in a day-to-day contact with the public. They can be caused by childhood illnesses, tuberculosis, HIV/AIDS, foodborne illnesses, sexually transmitted diseases. We want to make sure that we inhibit those by prevention and control. So we're going to immunize through immunizations. We're also going to educate. So we're going to educate food handlers on how to handle food so that foodborne illnesses aren't down. We're going to screen and do early treatment. We're going to do isolation for those who are infected if they need it. Work on control vectors, personal measures, so teaching patients to use condoms, proper hygiene, especially hand washing. Now, healthcare-associated infections or nosocomial infections usually occur within a healthcare. They always occur within a healthcare facility. They can affect a patient as well as a healthcare worker. Now, strains of bacteria in the hospital usually are more virulent and often resistant to antibiotics. Some pathogenic bacteria are no longer susceptible to previously effective antibiotics are found in hospital patients. An example, VRE is one example. The incidence of vancomycin resistance in patient with a nosocomial enterococcal infection is rapidly increasing. When using antimicrobial agents, they're going to look at the agent dependent, the site, the client's health status, their age, if there are any pregnancy and lactation going on, development of any kind of resistance. There's different classifications of these antimicrobial agents. antibactericidal, anti-infectives, antivirals, antifungals. So all these things they look at before prescribing. And here's just a concept map with different things talking about infection. That's on slide 95. Now, sepsis is the presence of a pathological microorganism in the blood. Systemic infection is usually early sepsis. SIRS is triggered when a local infection gets out of control. Like we said, sepsis is a systemic inflammatory response to documented or suspected infection. Now, this can lead to multi-system organ failure, septic shock, and also to death. So here's a chart with signs and symptoms of sepsis by different organisms. You might want to look over that. I don't know that there'll be anything on the test on that, but it is good to know. So conditions predisposing a person to sepsis or septic shocks. Usually it's a breakdown in barriers. Immunocompromised patients have a decreased immunity to infections. So let's look at some of these conditions. Malnutrition, immunosuppression, patients with large open wounds, mucous membranes with fissures in prolonged contact with bloodied or drainage-soaked packing, GI ischemia, exposure to invasive procedures. Those patients that have malignancies, people that are adults that are greater than 80 years of age, infection with resistive microorganisms, those patients going through chemotherapy, alcoholics, diabetics, chronic kidney disease, transplant recipients, those with hepatitis or HIV and AIDS, all those are susceptible to sepsis or shock. So some key points: what a nurse knows and does impacts our patients' outcomes relative to infections. So you get a call from a patient who was diagnosed from the hospital after an MVA, and she had her spleen removed. She reports she's having nausea and vomiting, and she feels like she has the flu. What are you going to do about that? So you have 3 patients. Let's say you have 3 patients you're responsible for. A new patient from an area of nursing home with pneumonia, from an area nursing home with pneumonia, with blood culture orders and IV antibiotics. A patient who is terminal and in the process of dying. Family members are crying and they call wanting to talk to a nurse. Or a patient who has been hospitalized for 1 week with a wound infection. You're 1 hour past the time for his antibiotics. Who's your priority? So think about that. Think about what we talked about, and you should have your answer. And we'll go on to the next section in just a little bit.